Good morning. It's Dr. John Bennett from Neurosurgical TV. This is the 22nd in the series of Daily Dose of Neurosurgery Education, headed by Ipcharian. And today we have the pleasure of having JKBC Parthaban. He's going to continue giving lectures on the spine. And welcome, JKBC, and it's all yours. And
thank you, John. And I'm very happy. My mentor, Professor Ramani, is here today evening. Good evening, Ip and my friends. And I'd like to continue my second part of this subject. The other day we saw the basics of clinical assessment of the patients, radiology. And today we are going to see something more, what we are going to do more with cervical spondylotic myelopathy. This subject I'm going to divide into two. One is about the guideline. Second one is the basic surgical approaches, surgical techniques. Now, I would like to put this slide. This is a modified Japanese orthopedic score, and this is the most popular score because this is the one which is used all over the world to assess. Now, if you carefully look, the score is done with upper limb and lower limb motor power, and then the sensory of the upper limb and sphincters. Totally, we have 17 points, and the minimum is, of course, 0. This you don't need to, you need to mark up that, but you can have this in your desk for assessment. When you see a patient, this one gives the functional assessment of the patient. Cervical spondylotic myelopathy, as we all discussed the other day, it is very complex disorder which has no borders. Radiology may look very bad, but patient may be looking very good. So this is the basic of the scores which is being used in the society as of now. Now, this can be modified slightly according to the countries and according to the places where they are. Now, in India, there's a small one particular upper limb motor function is being added. You can see here, able to button the shirt, but has difficulty in tearing the roti and chapati and scooping the rice. This is being added by the Indian neurosurgeons to make easier for Indian patients who come from villages. Now, the minimum score is about 18, and then we may have about 19, but basically we keep it up to 17. So we divide the severity of this neurological status of this patient of cervical spondylotic myelopathy into very mild grade. It's about 15 to 17. The moderate is 12 to 14, and the severe is less than 11. It's quite obvious. It's like we do see the Glasgow scale, and MGOA has this scale. So anything which scores between 15 and 17, we keep it very mild problems, and moderate is 12 to 14, and severe is 11. Now, with this background, we go to the latest what is happening in the world. There are some recommendations given in the world at present. One of the very popular recommendation is from Michael Felling. They have done from North American Spine Society, and they have created a very nice study, basic on various surgeons from Europe, mostly from Europe. They have come to some conclusions, and that is what enumerated in this slide. And this was published in 2017. Where we went through that, it was very excellent one because it is absolutely scientifically designed. But however, some of the things were not very strong, and you can see in the mild type particularly, the quality of evidence is very low, and the strength of the recommendation is also pretty weak because there is not much of consensus among the neurosurgeons, that is the practicing doctors. But whereas if a patient has got a moderate and severe, the quality of evidence is very, very moderate, and the strength of the recommendation is more strong. And so with this, this made us, that is we from the World Federation WFNS Spine Committee, we had a discussion to see how much we can do for this. Can we do something more? And we conducted one consensus meet, and that consensus meet gave a very nice vision on certain aspects of this disorder and to form a guideline. And subsequently, we published this guideline in 2019. In 2019, with the background of the 2018 conference, we published this in Neurospine Journal with the title saying that value of surgery and non-surgical approaches for cervical spondylotic myelopathy by the Spine Committee of WFNS. I will just enumerate what we have finalized as per the guideline. This guideline is also compared with the previous guideline, and this is very nicely given in the article which we have published. You can go through that, young neurosurgeons can go through that, but I will summarize this. Now, when there is a moderate and severe CSM, the recommendation is surgery. There is no doubt in that. The recommendation is surgery because we all know that 30% of the patients worsen and 30% stay the same. So one cannot wait for anything if you have a moderate to severe degree of neurological, functional neurology in the cervical spondylotic myelopathy. Now, when it comes to the mild cervical spondylotic myelopathy, which is about 15 to 17, we always suggest, first thing is, we suggest offering a surgery. These patients are very important. We suggest offering a surgery or a rehabilitation. Why rehabilitation? If a surgery patient is not going for surgery, then go for rehabilitation. But during this period of rehabilitation, during this period of the medical management, if there is a rapid progression, then we firmly suggest that the patient should undergo surgery. And there is no question about it because it shows that the patient is deteriorating. So the mild variety, though we suggest a surgery or rehabilitation, when there is a progression in a short period, then you have to say that this patient has to go in for surgery. Now, with very, very interesting fact is that many times the patient comes with absolutely no evidence. There is no myelopathy. There is non-myelopathic patient, non-myelopathy. There may not be any sign of myelopathy. They come with mild neck pain, and you often can see there's an evidence of cord compression, but there is no radiculopathy. So these patients are very, very difficult for us to take a decision when we sit in our consultation room. So we do not recommend any prophylactic surgery on these patients. But you have to counsel these patients. You educate these patients that they are having a very risk. They have a risk that they can deteriorate if they fall down. So even a trivial injury can deteriorate them. So this particular point has to be educated to them, the kind of disease they have, which is a very dangerous one. And they should be followed up regularly. And we usually now added one more important thing is that we have added that we have to get one informed consent from these patients that we have explained these things to the patients and the relatives. The reason for that is because if you see in the practice, many times we see the patients who come with quadriparesis or quadriplegia after trivial injury. If you ask them, they say that, yes, we had a consultation earlier. Then some patients say, refuse, no. They will say to one doctor, they will say one thing, another doctor, they will say another thing. So for documentation purpose, we have to get informed consent. This is an important point which we added in our guideline in the last recommendation from WFNS Spine Committee. Now, when there is no radiculopathy, that means the patient is reasonably stable. That is why this particular 5 points is being given. But if during this time, if the patient develops radiculopathy, that means there is the disease is progressing. Radiculopathy in a case where there is already evidence of cord compression is an indication of progression of the disorder. And so here we strongly recommended the patient for surgery or sometimes for rehabilitation. But in these cases, if the case is not willing, In case if the patient is not willing for surgery, again the patient need to be counseled very seriously, educate them, and get another informed consent very, very seriously, because the development of radiculopathy is a progression of the disorder of CSM. So if the same patient develop the signs of myelopathy during this time, they have to undergo surgery at the earliest. So this is the basic guidelines. I hope I have made it very, very clear. I'll go back and I will tell you very clearly, moderate and severe cases, you have to do surgery. In the mild case, you can offer a surgery or rehabilitation. If there is a fast progression of the disorder, you operate immediately. But when you see a patient without any myelopathic sign, you do not advise them for surgery. You get an informed consent, tell them that this patient, that you may go in for neurological deficit if you have a trivial injury. But if the patient develops a radiculopathy, advise them to go in for surgery at the earliest. That's all. So this guideline was formed by our World Federation WFN Spine Committee last year, and it is being now recommended all over the world. So the final word is, who would love to see our patient to deteriorate? So CSM, if you see in an average overall, even the patients who were on medical management, majority of the patients end up in surgery over a period of time. If not in an acute period, but somehow in some age they progress. Particularly if the patients are diagnosed very early in the age, for example, in the middle age, 40 years to 50 years, if they develop, invariably they progress. So it has to be taken very seriously. Now, having said that, then we go to the surgical part. I will make it very simple. This is because these studies, this class is being taken for the young neurosurgeons and postgraduates. So as per the guidelines from the neuro coach, I'm doing this. Surgical strategies, they're very, very simple surgical strategies. Last class, I showed this picture. You can see a very large canal on the left side, and you can see the myelopathic spinal cord on the right side. And this is the picture you saw in my last class. You can see the spinal cord is very free in this. The spinal cord is very much compromised and pinched, and it can get damaged further on movement, which we discussed last time. This is what in the flexion and extension, how it can compress the spinal cord from anterior and posterior. Now, the approaches for CSM approaches are anterior or posterior or both sides. Now, what are the anterior approach and what are the procedures we have? One is the anterior cervical discectomy and fusion. Number two is anterior cervical corpectomy and fusion. The third one is anterior cervical discectomy plus a corpectomy and adding on anterior instrumentation. Now, I'll show you some cases. We can go through that and it is more demonstrable. Now, ACDF is done when the pathology is at the disc level alone. When there is a disc collapse, osteophyte, single level, it can be single level, disc level, or it can be at multiple level disc level. Or sometimes you will have a disc level kyphosis, that is collapsing of the vertebral body, and you can see there will be kyphosis. In these places, an ACDF is good enough. Now you can see here it was C4 and C5. An osteophyte is there is a compression. Now in this case, a single level ACDF with the distraction cages, we have placed it. So this is good enough for a single level osteophyte. And another case, this is between C3 and C4. You can see here, there is a disc overlap, there is a disc and there is a calcification and it is being removed. Even in the X-rays, you can see posteriorly very well decompressed. And this is at a single level ACDF is enough in this case. Now, this picture I showed last time, in 2008, you can see a patient with myelopathy worsening, came in 2012 again. And this patient also developing a kyphosis. And you can see there is a degeneration is becoming worsening. Patient is also worsening. This is a very classical of the patient going from mild to moderate mild case to moderate. It was a doctor in profession, this patient. So this patient underwent 2-level anterior cervical discectomy because the compression is exactly at the disc level. Here you can see carefully, the compression is at the disc level. So we have done at the 2-level anterior cervical discectomy and fusion with the screws. These are the different type of interbody cages. So this is at 2-level ACDF. Now sometimes, very rarely, you can see this kind of a skip disc prolapses. You can see the disc region skip. There it is C3 and the C4. The lower level 2 levels are clipple field, and below the clipple field again you have a disc prolapse. So these cases we can do skip ACDF like this. In a single incision you can do at 2-level ACDF. This is a very old patient which I did some 10 years ago. I've not done at the clipple field above 1 level above, because the MRI, you can see very nicely the CSF spaces are maintained. So only at the disc level ACDF is enough, but you may have to do skip. Sometimes this is very, very rare and not very common. Now, another patient here, you can see here there is a collapse of the disc space at one particular level, and there is a mild kyphosis is starting. Now, this is a classical patient who can deteriorate very, very fast over a period of time. If you do an MRI, you can find the MRI is very moderate compression you can see the moderate compression where we have done at C5 and C6 level. The kyphosis at the C5, C6 level. So we have done at C5, C6 level, we distracted, put the cage, and also put an instrumentation because that level can further collapse. So an implant is added when you expect that the kyphosis or the vertebral body will collapse over the lower vertebral body can replace you. And biomechanically, you reconstruct the spine. You get a very nice lordosis. You can see in the postoperative X-ray. And the other 2 levels, you do an ACDF level. Because these are all only at the disc level compression. This is the compressive myelopathy at C3, C4, C5, and C6 at 3 levels. In spite of the disc level degeneration, there is still some cervical lordosis present. In these type of cases, I always do a flexion and extension view of the X-rays. In extension view, now if you find the lordosis is getting improved, they are very good cases for an anterior approach with anterior cervical discectomy. So I also have done this standalone 3-level cage fusion in this case, and I have increased the lordosis. Now, when we use an autografts from iliac crest grafts, we have already done research for many, many years ago with me and Professor Ramani. We have done some 25 years ago that autografts, when it fuses, it settles down. When we fuse, it settles down. But with these type of metallic cages in between, in anterior cervical discectomy fusion, metallic cages, they hold it like scaffolds. So the collapse is less. So the loss of lordosis is very less. So in the process of fusion, the collapse is less. So 3-level standalone cages can be done. We have not done more than 3-level, but up to 3-level we have done in many, many patients. In some cases, we have added yes. Yeah. In some cases, we have added the instrument here in ACTF with autograft, because we know the autograft collapse in very, very long cases. In this is a 3-level, I have added the anterior plating to maintain the kyphosis, to maintain this, to maintain the lordosis and prevent the settlement of the graft. When there is a progression of kyphosis, when you expect the progression of kyphosis, it is always better to do an anterior instrumentation, which you can stop the kyphosis from coming up and maintains the lordosis biomechanically. So the 2 aims is that, one, you decompress the spine from anterior, but at the same time biomechanically give a good biomechanical spine. Now the carpectomy, when we do the carpectomy when the vertebral body level compression is seen. or a single level or multiple level. Sometimes you have multiple level disc degeneration with a reduced vertebral body height. Sometimes there will be an associated subluxation and kyphotic cervical spine. So these are the complex situations where you come across vertebral body level compression. For example, in this case, there was a vertebral body compression at one level. The corpectomy has been done. This is a distraction cage done. And this is a postoperative picture which shows the neutral extension and flexion. After many more than 1 year, still there is no problem. So what it means is that a corpectomy can be done without instrumentation, but at the same time, when a lordosis is maintained, you can do this. If it is not maintained, you have to supplement with an anterior plating. Now, in this case, you can see very, very bad spine here. You can see there is a subluxation, and also there is a reduced intervertebral disc space at one level, and there is a cord compression. This needs a good corpectomy. So this is how we have done at C5 level. C5 corpectomy is completely done, a good decompression, and then stabilized with a distraction. You can see the cage there and anterior implant, because here the anterior implant is very much important. And if you don't the anterior implant, it will tend to fail. Compared to this case and compared to this case, there's a big difference. You have to be very careful in case selection. So that is why I'm showing these cases. This is another patient you can see here. The kyphosis is progressive kyphosis, the multiple level compression, vertebral body level, there's a cord derangement is there. So we have used at multiple level, I have done the decompression, a corpectomy at C5, and then we put it with the iliacus graft, and that region I put with an implant. And one level above, I have done an ACDF alone with the interbody graft. This is to maintain the biomechanics. So not it to form, become kyphotic in future and come for a resurgery later on. So you should be pretty careful in cases. So this range of cases will show you how we go in for anterior approach. So when we do it for posterior approach, there are posterior procedures. We have a laminectomy, laminoplasty, plus or minus posterior instrumentation. I'll make it pretty short here. Now, when do we do laminectomy? We do laminectomy when there's a good lordosis. There should be good lordosis. Kyphosis should not be there. And many times we see posterior compression. Not only anterior compression, but you will have a posterior compression because of the thickened buckles, the ligament of flavum, which impinges from back, and because of the laminar crowding and spurs forming. So it forms both anterior and also posterior. So buccal ligament of flavum, laminar crowding, and sometimes with ossified ligament of flavum. Sometimes, very rarely, you will have multiple anterior compression with no instability or lordotic spine. This gives an indirect decompression. The last point is that where you do have a lot of anterior compression, but in very old patients, there is not much instability. They all fuse in all sides. Then those cases, you can subject them for laminectomy. This is you can see very classically you have a posterior impingement at one level, and this patient we have done only one level laminectomy alone, just one level laminectomy, and the patient has doing very well post-operatively. This is another patient. You have seen multiple level disc there, and also posterior compression is here. Here there is no kyphosis. Here there is a straightening is there. When you do an X-ray extension, you find very nice lordosis. So this patient underwent laminectomy. You can see the spinal cord very nicely decompressed after that. This is a post-operative picture, post-operative MRI after 1 or 2 years down the line. It shows very nice decompression. Sometimes we also see, very rarely you can see this kind of patients. This is what I was telling. In some patients you have, there is a straightening, though there is not much of loss of lordosis. Very old patients, they do not deteriorate later. After laminectomy, you find a good decompression, but there is no progression. But in these cases, if there's a progression, you should not hesitate to instrument this patient if the patient is, number one, is fit enough to undergo surgery, number two, is willing for another surgery. There are something about suspension laminoplasty nowadays, we are not doing it. So I like to skip this suspension laminoplasty, but we have done suspension laminoplasty with thinking that, this is going to give that posterior strengthening after decompression. In few cases, we have done like this. In C3, C4, you can see here, a good lordosis is maintained. We have just done a decompression from posteriorly, and we are able to increase the canal volume, volume there, and give the spinal cord more space. You can see those lines which I have drawn at C3 level, at C4 level, and C5 level. It increases by that. This is only suspension. That is, you do a gutter on the laterally and lift the spine and the lamina as a lobster, and one all together, and give the spinal cord a decompression, the posteriorly. And when we do, when we have to do this instrumentation, that is when we should do a lateral mass fixation, because those patients which you think that they may progress, those patients, particularly in the younger patients, in the middle-aged patients, when you do a laminectomy, you find that there is the lordosis is not to your happiness, or if you have, there is a subluxation. When you think that there is it may progress over a period of time, then it is always better after doing a laminectomy, you can do a nice lateral mass fixation. It's a very classical case. You can see very, very multiple level cord compression from nearly 4 or 5 levels, or the 4 level, 5 levels there. So you do a good decompression, and then put the your lateral mass screws and plates so that you can hold it, and it does not allow the patient to go in for a kyphosis and then again compress. Or patients, sometimes they may come after some time, they will come back for another surgery. So you can do a preventive measure by doing a lateral mass fixation. Now this is more or less similar to our OPL management, and this is the same thing can also be used in CSM. Like whenever there is a K line is positive, you can see the K line is positive, you can do a posterior approach. When there is a K line is negative, you can always prefer to do an anterior approach. So in summary, I have to conclude here. In summary, there are very, very clear lines where you have to do an anterior approach, and then where you have to do a posterior approach. I have given few case examples. Now, as far as the techniques of doing this, how to do ACDF or how to do laminectomy, I would like to take it in another class, maybe next week. Thank you very much for your kind attention. Thank you.
Well, thank you, Parthy. Thank you very much. Excellent class as usual, elegant and simple. This is exactly what neurosurgery coach wants. So I would look forward to your next class, Parthy. Thank you very much. It's always an honor to have you around.
Yeah, sure. Young neurosurgeons.
I have a question.
Yeah, go ahead, Dr. Kabulo.
Yes, I said, how many levels can you do laminectomy without instrumentation?
Yeah, Dr. Kabulo. See, it's a very nice question. I have a patient I have done for 7 levels. 7 level. It is not in this presentation. I like to show it in my next class when we talk about the laminectomies. The important point is the case selection. The kind of case selection is most important. We have done 6-level laminectomy with instrumentation from C1 to C7 we have done, but at the same time we have done without instrumentation too. So it is absolutely about how to select the case. So if the patient is, if the spine is very rigid and fused and very aged patients, those patients you can always do a laminectomy without instrumentation. But if the patients are younger patients who can progress, can have a kyphosis, then it is better to instrument.
Okay, we have a question from the panel, Doctor. Is there any grading of severity of cervical compressive myelopathy?
Any grading? Yeah. See, that is what I said about the grading is concerned. We would like, as of now, there are so many papers, so many schools of thought about it. But as of now, I would like to do the functional grading. Like the modified Japanese orthopedic association is very simple. It is a functional grading is sufficient enough for treatment of these patients, because now our indication for surgery is it depends on the functional rather than radiological, because the radiologically sometimes you have a severe compression, but if you see clinically the patient may not be showing any symptom, so it is very difficult to assess. So the best thing is the functional scoring method.
Okay, we have a question from Mayank. Do you want to ask a question yourself, Mayank? Or you want me to ask it?
Hello.
Go ahead.
Sir, is it audible, sir?
Yes, it is. Thank you.
Sir, can you please guide some criteria regarding 360-degree fusion, anterior and posterior?
Okay. See, there are a few things I would like to suggest. 360-degree means there are only 2 points. One is we are expecting an instability. This is the first thing. That is the first thing is instability. Number two, sometimes you have both anterior and posterior compression.
Okay.
So these are the 2 points which we have to take it. So if we have both anterior and posterior compression, because in young man, for example, a patient has got an anterior compression and also a buckling of ligament from posteriorly at one level, you do anterior cervical discectomy and distract, the ligament will, if it is in a young patient, the ligament stretches out and you also achieve a posterior decompression. But this does not happen in some cases in older patients where the spine is fixed. In those cases, they do not work. The ligamentary taxis does not work. In these cases, you may have to do anterior first, but if you have a posterior compression existing, then you do it as a second sitting in the posterior, which we have done few cases like this. So your 360-degree is number one. One is instability. Number two is anterior and posterior compressions together. Now, if you careful, so that is why your MRI studying the MRI is very important. Many times the patients have incomplete decompression. We call it as incomplete decompression. Whether you do a laminectomy in a patient with a kyphosis or do a laminectomy with a straight spine, and you find laminectomy is very good, but the spinal cord has not moved back.
Okay.
So you may have to go in again anterior and do it. So you have to reassess the patient during your follow-up period. Am I correct? Okay.
So one more doubt, sir. You told that sometimes ligamentum flavum buckling will resolve with time. So we should give one anterior trial and follow the patient. We should not done 360 at a time in one sitting.
Yes.
Always.
See, if
that should be the thumb rule.
Yes, thumb rule. If the patient is young, I'll give you one more point. Important point is you do flexion and extension X-rays, right?
Yes, sir.
Now, if your extension shows a very nice lordosis, that means your ligaments are good.
Okay.
So that helps you a lot. The ligament is very nice. So when you distract it anteriorly, automatically posteriorly the ligament of flavum will stretch us up.
Okay, very good. Khalif?
Sir, I have a question here.
Okay, go ahead.
Thank you so much. Prof, I wanted to ask you a question. For the SCDFs, we see some spine surgeons who do it without microscope using loops, and some people will say that they'll never able to do this without microscope. In your experience, do you think it's possible to do adequate decompression without using the microscope?
Yeah, it's a good question. But in the present era, in the present level, I think we have to use microscope. It's very difficult without a good microscope and good vision to do an adequate decompression. But with your experience, some surgeons do with their experience, they do very well. This is particularly, even why I'm telling about this is the loop also a magnifying instrument. So you can also use a loop. It is not that 4x and 8x loops you can always use, but a microscope is a microscope. So we recommend a microscope in ACDF. But if you don't have a microscope, you can do with a loop, but not with a naked eye. Never.
Sir, I have a question here.
Yep.
Go ahead.
In case of severe posterior compression,
Yep.
after decompression, there is deterioration, which they say is documented as white card syndrome. What is your experience of that, sir?
I'm very sorry to say a few things. So my teachers are there. I can see Dr. Suresh Babu there. See, I can see, I see Dr. There are my seniors are there. There are few things we have been taught. We were taught like this, sudden decompression, intra card hemorrhage. These were the old, these were our elders were telling about it. But I don't believe this. Because in those days, the instruments what they were having were not to the best of what we have now. Now we have a better instruments like 1 mm Harrison punches. So majority of them is first is surgeon induced. I would always say that if there is a patient is deteriorating post-operatively, it is because of our technique is not. The first is surgeon induced. Number 2 is whatever we call, whether it is a white fiber, this one, or hematoma. They are all maybe surgical faults. In my personal view, I would like to show, maybe in the next class, I will show the technique of how carefully you can do the decompression from posterior in microsurgery.
Okay, Rajesh Nair, go ahead. You have a question, go ahead, unmute and ask your question. Go ahead.
This is a question. Hello.
Go ahead, Rajesh.
Yeah. So in cervical OPLL, what do we prefer? Is it the anterior or the posterior approach? Because most of them, they recommend
Sorry, I'm not able to hear you.
Hi, good evening, sir. This is, I just wanted to ask that in OPLL, cervical OPLL, most of them, they prefer a laminoplasty, but however, it is an anterior compression. Some people also prefer going anteriorly. So what is the recommendation?
It's very difficult. It's all surgeon skill level. I tell you, see, one is OPL is a different subject altogether. It is not like CSM what we are discussing now. As I showed you that K line positive and K line negative, so we have to be very clear about that. So if there is a compression from anterior and there is a kyphosis, then it's better to go do only an anterior approach in OPLL. Up 2 level to 3 level, it is good. It is easily can be done, but more than that, it is very, very difficult. That is why a lot of surgeons have gone to posterior approach because they are more safer. Now, posterior approach, you can do it at any number of level, but if you add lateral mass instrumentation, it reduces the progression. Because as far as OPLL is concerned, the mobility increases the OPLL formation. It never ceases. Even after decompression, sometimes Japanese neurosurgeons say that the ossification comes back in some level. So the movements, the micro movements which are stimulate the ossification. So the best thing is in those concept wise, I would like to do a lot of lateral mass fixation along with laminectomy in OPLL.
Okay. Thank you.
Okay, more questions, comments?
Hello.
Yes, go ahead, Ayman.
Hello. Thank you for this nice presentation. I want to ask you about when do you apply plates in ACDF and when do you not apply? Thank you.
Okay, yeah. I routinely I don't apply plates in ACDF. Anterior cervical, routinely I don't. But I use it only in specific situation. Number 1 is that when I expect an instability in that level, number 1, that there I usually put the plate, that apart from whatever graft, interbody graft I put, number 1. Number 2, that the plates are used when we expect a kyphosis is going to come after your decompression. That is, you expect it. That is, you foresee that there is going to be a kyphosis at one level or subsequent. For example, that you have one more level, the patient has also a degeneration. But a single level, I don't use plates. I do standalone interbody grafting. Next class, I will show you how we do the ECTF. Yeah.
Rajesh Nair, you had a question. Unmute and introduce yourself and ask the question.
Good evening, sir. I'm Dr. Rajesh. Is it audible?
Yes.
Yeah, Rajesh.
Yes.
Sir, can you just guide us the follow-up you use? Like when you do take the X-ray, when you do take the post-op MRI,
Okay.
how do you follow up a case after a decompression?
Okay. See, my routine practice is that the ACTF is, if it is done in the first day, and immediately we do the X-rays. That is the next day or the mobile day we do the X-ray. This is to confirm what we saw finally in the C-arm. So number one. Number two, our routine is that the first follow-up in the first 15 days, 3 months, 6 months, 9 months, and 1 year. This is what I've been following X-rays. As far as the MRI is concerned, usually now when you routinely we do it by 1 month or third month. But if you suspect, in case you find that there is no improvement or you find there is some problem, patient says that I'm not happy, then you do, you ask them to get an MRI earlier.
Okay, more questions, comments?
Hello.
Yes, go ahead.
Hello.
Introduce yourself and ask the question.
Good evening, sir. I'm Dinesh, sir. Sir, I have a question. How important is this T1 slope measurement and neck tilt angle measurements for?
Yep. Yeah, they are T1 slope and neck tilt angle measurements are very important. This is what you are trying to say is about these are the measurements to find whether we are the patient's spine is biomechanically stable, particularly at the lower cervical spine regions. So I would like preferably we do all these things because when we do at the C6 and C7 instrumentation, so this will help us to instrument or not to instrument. You got my point. So to instrument or not instrument, in case if you have this will give you the progression that this patient is going to lose the lordosis and going to more kyphosis. So they need instrumentation on top.
Okay, sir.
So the measurements is a part of our work. Like for example, that all cases we do the angulation of our lordotic angle, all patients.
Okay, sir.
First preoperatively, preoperatively with flexion and extension and neutral, and then postoperatively also we do that. So this gives us the progression. Yeah.
And sir, about the use of collar, how would you recommend the use of?
Use of collar usually at the single level collars. I don't know, but at multiple level, I always give them a soft collar. But if your stabilization, if your instrumentation is very good, in fact that you don't need a collar. But a collar gives a good protection to the patient, and patient also feel that they are within a control. Otherwise, they are over enthusiastic. Like some of my patients, like to travel. Some doctors would like to operate immediately after the surgery. They immediately remove the collar, and I showed one of the patients where I put the graft with the pins. You saw that the zero piece. That's a doctor. That lady, she wanted to operate immediately. She fixed it, and then she went in for surgeries. So it's very difficult. So collars, I'm still skeptical at one level, but at multiple levels where you feel that there is instability, you feel that it needs protection, then it is better to give a soft collar or a Philadelphia collar.
Okay, more questions, comments?
Yep, I think Atul is getting ready. Atul ji. Hi.
Okay,
John.
Yes, go ahead. Yeah,
get ready to wind up with this, John. I mean, if Professor Atul Goyal is there, let's have him on the panel. Is he around?
Yes, he is. Yes, he is. Yeah, so let's end this formally. Thank you very much, Dr. Bardhaman, and we'll see you in next class.
Yeah, thank you.
Marty, just tell us when just tell us when you can take the next class, and we'll schedule you on, Marty.
Yeah.
Thank
Next
you
week.
so much.
Next week, surgical techniques of ACDF. Yeah.
Done.
Okay, great. Okay, good morning, John Bennett from Neurosurgical TV. We're going to move on to our next talk with Dr. Atul Goel. It's all yours, Dr. Goel, and thank you for coming. You there, Dr. Goel? I saw you.
John,
There
can
you
hear
are.
me?
Yes, we can.
He's there.
Okay, internet is a little bit weak here, but I hope I can complete my presentation.
Okay.
So I'm going to actually talk to you. Just let me get set a little bit.
Okay. We surprised you, huh?
Hello, John?
Yes, we can see.
We can hear you. We can hear you. We can see
you
the
can
screen.
See my slide?
Yes,
Yes.
You make it bigger. There you go. Perfect.
Okay.
Perfect.
And John, what I will suggest to you, because the internet is a little bit unstable, and I am removing my earphone, as you can see. If you have any message, just wave your hand, okay?
Okay.
Okay. Or maybe whatever way you have to give me a message.
I can text you. Okay.
Okay, so let me begin with this beautiful subject of pituitary tumopathy. I enjoyed your lecture, and I'm looking forward to your next class.
Thank you. Sure.
So I'm going to go through the story of pituitary tumors. Pituitary tumors are absolutely wonderful neurosurgical issues. You can give new life to the person immediately after the surgery. If the tumor is hormonally active, like for acromegaly, you operate, beautifully you operate, and in the evening the person can say, doctor, my fingers have reduced in size, my nose has reduced in size, my skin is brighter, and so many other things. Means that you get a new person. You operate on a Cushing disease patient, you do a beautiful operation, and you give new life. And for Cushing disease in particular, surgery is the only answer. You can give cure to the person. You can give absolutely beautiful life to the person. Patients coming with visual loss. You operate in the morning, and in the evening, the person can have normal vision or improved vision. So pituitary tumors are one of the more dramatic neurosurgical issues where you enjoy doing it and patient also has a wonderful result. The issue in these cases is that you have to do a beautiful operation. You have to do a radical, complete operation. There is no role for partial surgery or incomplete surgery or little surgery or biopsy. There is no role of these kind of operations. Like for Cushing disease, if you remove it completely, complete nodule has to come out and you cure the person. Acromegalic, you have to remove it absolutely radically, you cure the person. So surgery is how you operate, and the extent of radical approach that you have in your mind will determine the outcome. You have to learn pituitary surgery, and you have to actually, you develop this art of exposure, the art of removing the tumor, the art of breaking the tumor, and there are various issues that you have to learn with time, and you have to learn it properly. I am going to take you to a different world, not a regular world Nice.
You lost your sound.
Yeah, we
You
lost
lost your
your.
sound.
I'm going to take you.
Yeah, I told you. Okay, there you go. There you go.
Giant pituitary tumors.
There you go.
And I have to tell you that giant tumors are giant in size, but not malignant or aggressive in histology. They are benign tumors. You do a good job, you do a radical job. Of course, the recurrence rate is much higher than smaller tumors, but in giant tumors, the tumors are not malignant. Most often, more often than not. So radicality of your surgery is the issue. The question for you is whether you understand these giant tumors. So I'm going to show you some giants, okay? So this is one giant pituitary tumor, and you see this giant is like a lion. Whether you want to put your finger in this lion's nose or not is the issue. Whether you want to disturb this sitting and relaxing lion is the issue that you have to decide for your own self. On the other hand, you do a good job, you do a radical job, you understand these tumors, it can just look like a beautiful flower. So I work in a public hospital, as I mentioned yesterday, and this hospital, I get an opportunity to see several neglected cases, several large cases, and one lecture I had given in the Mount Hill of this beautiful mountain. And this is the kind of mountainous tumor I showed in this meeting. And this was a meningioma, of course, but this was the largest meningioma and the heaviest meningioma that we had reported at that time. So sometimes I have been traveling all over the world. I have been giving lectures on giant tumors. I have not seen too many people talking on giants. So let me show you some giant pituitary tumors. So this is one giant pituitary tumor. You just see the beauty of this tumor and just imagine how you are going to deal with this problem. And I am also telling you, so this, because my internet, I am working from home, my home internet is not good, so you just have to bear with this. If you have to see these giants, you just keep a giant like heart for me. So this is another giant. This is the same giant. You see this giant pituitary tumor? And this is another giant of a pituitary tumor. You can see how it is related to the internal carotid artery, how it is related to the cavernous sinus, how it is related to the diaphragm celli. You have to see it. This is another tumor, huge giant tumor. And I'm telling you that this is not a malignancy. This is a benign tumor. This is a benign pituitary tumor. This is another giant. And I have to show you and I have to discuss with you as to, is there some method in this madness? These are madly spreading tumors, going from one corner to the other corner. The decision regarding what approach has to be taken perfectly. The tumor has to be understood perfectly. You see, this is another giant pituitary tumor. This is another huge giant tumor. This is another giant pituitary tumor. This is another giant. This is a giant of different kind. And you see this giant is extending more into the paranasal sinuses. This is another giant. This is another beautiful, I call them beautiful giant. So this is the head of the person. It is not me. Okay, now I'm sorry for all this mess, but unfortunately it is beyond my control. So here, you know, the giant tumors are different. Giant tumors are not the routine pituitary tumors. Giant tumors are absolutely mad in their growth pattern. But as I mentioned to you, there is a method in this madness. And that method has to be understood. So in this presentation, I'm not going to show you the videos, but going to show you some tumors. And in my next presentation, I'm going to show you the videos of pituitary tumor surgery. Here, I'm going to show you my concepts, anatomical relationships, and surgery.
Use microphone. Use microphone.
Whatever I'm saying is quite heavily published, as you can see, in various publications of mine over several years. So now I'm doing pituitary tumor maybe over 35 years. So I'm going to compile my presentation on the basis of this work. And these are some more articles on the subject and several book chapters in various books. So now the basic concept, and I think this concept has completely, in my estimation, revolutionized pituitary tumor surgery. Now you will ask me, what is that concept which has revolutionized pituitary tumor surgery? The concept is, for the first time in the history of pituitary tumor surgery, we mentioned in our article about 20 years ago, that this tumor is under the diaphragm, and the diaphragm is elevated on the dome of the tumor. So this we had published for the first. Now let us see. Here, now you see here, it is very clearly seen in this image that the diaphragm cell is elevated by the tumor. So as I mentioned, 25 years ago, the concept was there is a dumbbell here. Half the dumbbell is above and half the dumbbell is in the enlarged sella. And the upper dumbbell is in the subarachnoid space. And when you can imagine that it is encasing, if it is subarachnoid, then it is in very close proximity to the circle of Willis and other things. That is the reason that these tumors were operated by a transcranial route. Now here also in this tumor, the diaphragm is completely loaded by the tumor. It is on the dome of the tumor. So that is the concept. No matter how big the tumor becomes, the diaphragm remains intact. I'm not talking of all the tumors, but in majority of tumors, and I will show you which tumors it does not remain intact. So if you come by transnasal route and remove this anterior wall of the sella, you can debulk, and ultimately the entire diaphragm will come down. So this was the revolution in pituitary tumor surgery. The diaphragm remains intact. The tumor does not go into the cavernous sinus. Those kind of tumors we graded as grade 1 tumors. You see this tumor is going right beyond the corpus callosum, but the entire diaphragm is going to be intact, or the dura of the diaphragm is going to be intact. That is the concept. And this concept is the one which we propagated for the first time in the literature. And whether you are using microscope or whether you are using endoscope, those are different, you see, but this is the concept. So I'm showing you some more tumors with this. You see the dura is intact, the diaphragm, the tumor is not going into the cavernous sinus. When it goes into the cavernous sinus, it encases the internal carotid artery completely. Here in this case, it is in proximity to the carotid artery, but it is not entering into the carotid artery. So you see this beautiful tumor where the diaphragm is completely intact. And this is another tumor where the diaphragm is completely intact. It is not going into the cavernous sinus. And these kind of tumors we call grade 1 tumors. This is grade 1. You see, it is not encasing the carotid artery. It is going completely, the diaphragm is intact. These are grade 1 tumors. So this was one of the papers that was written. This is grade 1 tumor. Even when you see dumbbells like this, and nodulations like this, it does not mean that the artery is encased. The artery is on the dome of the tumor. Even when there is a small nubbin like this that you are seeing here, it does not mean that the diaphragm is transgressed by the tumor. So you try to understand my point that there is a method in the madness of pituitary tumors, and this method we have to completely and very elaborately understand. Even when there is a nodule like this and multiple nodes like this, the cellular dura is intact, the diaphragm cellular dura is intact, and the only way to do this operation is by the transnasal route. Transcranial route is completely historical for pituitary tumors of this kind. Even when there is a nubbin going into the brainstem like this, even when there are multiple nubbins like this, the cellular dura is intact and the cranial dura of the diaphragm celli is intact. Even when there is a nubbin, like huge nubbin, one nubbin, big nubbin here, smaller nubbin here, it does not mean that the diaphragm is transgressed. And those who are doing pituitary surgery will clearly understand the huge importance of what I'm saying. It is not a minor point. It is not a very, point which can be ignored. This is a huge point, huge. Those who do these kind of tumors and those who are involved in these kind of radical, massive tumors or tumors of any kind will clearly understand the meaning of this. This is not transgression of the dura. This is within the dura. This is within the dura. There is no artery within the tumor. You remove the tumor, remove, and ultimately the entire diaphragm. The question is how you remove the tumor, which I will like to, these tumors are not firm. These are vascular, but these are not very firm tumors. You have to remove this tumor, and that art of removing the pituitary tumor has to be learned. This is subfrontal extension of the tumor. And believe me, my friends, this was a clear indication several years ago to do a transcranial surgery for this. But even in this situation, the diaphragm is intact and this tumor can be removed in about 15 to 20 minutes without any issue. The whole anterior, and there is no need to remove this planum sphenoidal and tuberculum celli bone. You can remove the tumor here, and ultimately you have to learn how to get this diaphragm into the picture. You see, this is another beautiful case where the diaphragm, the tumor is going anteriorly or posteriorly, the dura is intact. You can remove this tumor, and even this part which is going anteriorly, you do not need to open the planum sphenoidal or tuberculum celli. You can remove the tumor, learn the art of breaking the tumor, and you cannot work on this tumor for 5 hours or 10 hours. These tumors have to be removed in quick time. I'm not saying 5 minutes, but not more than half an hour or 45 minutes. If you're working on this tumor, then you may have very serious problems, because if you are going to operate on these tumors, you have to do a very radical resection. You cannot do partial resection. You do partial resection in these tumors, you create a huge complication. If you are not very confident of removing it completely, it is better not to touch these tumors, because pituitary tumors of this type, you may have a mortality at hand in the evening. You do a good operation, this patient who comes with only visual problem, many of these tumors are non-functioning tumors, and most of these tumors come with only vision as the problem. And in the evening, you go and see the person will be able to see better. He said, doctor, I can see you. On the other hand, believe me, if you do a partial kind of resection, a smallish resection, this patient may have a bleeding episode and you may not be able to see the patient. So either patient sees you and you see the patient, or nobody sees each other. So that can be the issue. You have to really do a very fantastic job in these tumors. So this is another tumor. And as I mentioned to you, my aim of my presentation is to show you the anatomical concepts of these tumors, which, believe me or not, were not existent 20 years ago. Sometimes if you see multiple nubbins like this, here usually the diaphragm is relatively thin. It is quite a thin diaphragm. And in that situation, you have to see whether you have to, how you have to get the diaphragm into picture. But essentially, what the meaning of the purpose of my presentation is to tell you that the role of transcranial surgery, which was quite predominant 20 years ago, is completely wiped off by this one single concept. And if you don't have this concept, you just cannot do these tumors. Grade 2 tumor, you see, this is the internal carotid artery which is encased by the tumor, and the tumor is entering into the confines of the cavernous sinus. These tumors I call grade 2 tumors. In non-functioning tumors, whether to remove this part of the tumor or not is an issue which is discussed quite elaborately in the
shortly.
Now here you see,
yeah, it's okay.
Internal carotid artery is encased by the tumor, and that is when I call it cavernous sinus extension. Here also the diaphragm is intact. Cavernous sinus is involved by the tumor. When to do this tumor, when not to do this tumor is an issue which we will discuss at a later stage. You see this tumor is entering into the cavernous sinus on one side, and cavernous sinus is very heavily involved by the tumor. The diaphragm is here. This entire part of the tumor is within the cavernous sinus. This issue about the cavernous sinus and the medial wall of cavernous sinus we have discussed in one of my articles, and which I will show you in my presentation, and we have discussed this medial compartment of cavernous sinus. This is not a pituitary tumor, this is cavernous hemangioma of the cavernous sinus. No matter how big cavernous hemangiomas become, they can go towards the pituitary glands. They can go in the intercavernous sinus, but they never transgress the dura of the pituitary gland, period. You see, it is going near the pituitary gland, but will not be able to transgress the dura. So the issue is why such a tumor is not able to transgress the dura, and why some pituitary tumors transgress the dura is a very difficult question to answer. And I will like to show you the medial wall of cavernous sinus at some point. This is one article I had written long time ago as to how the pituitary tumor, like this tumor, is going on both the cavernous sinus, but does not squeeze the artery. This is a meningioma, it squeezes the artery. This is a nasal tumor which is displacing the artery. So on the basis of how the arteries are displaced or encased, you can actually know the histology of the tumor. This is one tumor. It is entering into both cavernous sinuses. You can see both the internal carotid arteries are encased by the tumor. But the diaphragm celli is intact and the lateral dural wall is intact. Lateral dural wall is intact this concept was not existent in the literature 20 years ago. My concept is the lateral dural wall of the cavernous sinus can never be transgressed by the tumor. This is another tumor. You see the diaphragm celli is elevated by the tumor. Cavernous sinus is involved by the tumor. Lateral dural wall is not transgressed. Diaphragm celli is not transgressed. Believe me or not, those who are involved in surgery on these tumors know it, that this concept is absolutely important for those who are going to operate in this area. So pituitary tumor and cavernous sinus involvement, I have written several articles on this, and those who are in this must have read my articles. So here you see the diaphragm is involved, is elevated, the lateral wall is displaced, and the tumor is involving the cavernous sinus. This is the tumor which is going into the paranasal sinus and involving both cavernous sinus. I call these tumors grade 2 tumors still. Now you see the beauty. You see the lateral wall of the dura is intact. The diaphragm celli is intact. In this case, this is a different patient. The diaphragm celli is ballooned and stretched very heavily. It is ballooned but not transgressed. Lateral wall of the dura is ballooned but not transgressed. You see the beauty of these images? Now you see another tremendous image, tremendous. You see here, this is another case. This is grade 2 patient. You see the lateral dural wall is intact. The dimension of the internal carotid artery is intact. It is not squeezed. Now you see the difference in this picture and this picture. This is the diaphragm celli, and this is the roof of the cavernous sinus dura. This is the lateral dural wall of the cavernous sinus, which is not transgressed. This is the roof of the cavernous sinus. This is the dura of the roof of cavernous sinus. This entity we described for the first time in literature, that this elevation is quite a common event, quite a frequent event in the pituitary tumors. You see here the roof of the cavernous sinus dura is elevated by the tumor. The lateral wall is intact. The diaphragm celli is intact. And this tumor is within the confines of the cavernous sinus. Now you see this beautiful image. This is another patient. You see the diaphragm celli is elevated by the tumor. Can you see that? And the roof of the cavernous sinus is elevated by the tumor. It is not, dura is not transgressed here. Lateral wall of the cavernous sinus is intact. If you take a cut section, you feel one tumor, but part of this tumor is within the confines of the cavernous sinus, within the dural confines of the cavernous sinus. Cavernous sinus is an extradural entity, and this tumor remains in an extradural compartment. Now you see another tremendous image I'm showing you. This is the diaphragm celli, which is elevated. And this is the elevation of the roof of cavernous sinus. Do you see it? It cannot be more clear than this. And if you take a transverse section like this from here, like this transverse section, you see one small nub in here, and this is the bigger part of the tumor. This is the entire tumor is within the confines of dura. This is the dura of the diaphragm celli. This is the dura of the roof of cavernous sinus. This is the dura of the lateral wall of the cavernous sinus. So on the basis of this, we have written some articles which I wish you will like to read. So now you see this is tumor which is quite a complex kind of tumor. You know, you will not imagine 20 years ago, before the era of MRI, for sure, nobody knew how this tumor was, because on CT scan, you cannot imagine this. These lines that you are seeing here, these lines were not readily seen on CT scan. So this concept has actually come in the era of MRI. So for the first time in the literature, we said that this tumor is not in the temporal brain. This tumor is certainly intracranial. It is certainly intracranial, but it is subdural or extradural within the roof of the cavernous sinus. This is within the confines of the cavernous sinus. This is underneath the diaphragm celli. So this is not a haphazard kind of tumor. This is not a tumor going here and there. Oh, this is a aggressive tumor. These are not aggressive tumors. These are histologically benign and behaviorally benign tumors. You understand these tumors. If you understand these tumors, you can do a very fantastic surgery on these tumors and you can give a new life. This is another beauty I have got for you. Now you see here, the diaphragm is not elevated. Both roof of cavernous sinuses are elevated by the tumor. Both cavernous sinuses are involved by the tumor. Internal carotid arteries are encased by the tumor. This is another very fantastic tumor that you will see here. The tumor, the diaphragm celli elevation is here. This is the roof of cavernous sinus on one side and roof of cavernous sinus on the other side. Both the cavernous sinuses are involved by the tumor. You take a cut section here and you see two nubbins, and you see this is the part beyond, this is the part here. So the diaphragm elevation is not there, but the roof of cavernous sinus elevation is there. So if you do not understand the cavernous sinus, if you do not know that this part is not under the diaphragm, but it is in the cavernous sinus, you will certainly miss this tumor. So if you are going to resect, I am not saying now when to resect and when not to resect, which I am going to discuss with you. But if you are going to resect, you have to remember that you are working within the confines of cavernous sinus when you are going to remove this tumor. Another very fantastic tumor you see, if you see this picture, you will see that this is a very routine kind of pituitary tumor. But this is not a routine tumor. Here you see how it is elevating the roof of cavernous sinus and how this roof of cavernous sinus is elevated on the other side. This huge tumor, this diaphragm celli is elevated like that. This small nubbin that you are seeing, and you are seeing this cavernous sinus, you see this tumor is, the tumor elevates the dural roof of the cavernous sinus. This is the dural roof of the cavernous sinus and the elevation by the tumor. This tumor, you see, I had seen some 20 years ago, and in all my presentations, I like to show this beautiful tumor. This is like a trifoliate leaf. This is the roof of the cavernous sinus. This is the diaphragm celli. This is the roof of cavernous sinus. Roof of cavernous sinus, diaphragm celli, roof of cavernous sinus. This is a well-defined tumor. You have to understand this dural integrity of this tumor if you have to remove this tumor. Believe me, my friends, this is not a minor issue. This is just not a minor issue for the surgeon who is going to do this tumor. If he does not understand this dural anatomy, please do not enter into this juggernaut of tumor. These are difficult problems, and I have mentioned that you remove it partially. It is a sure shot sign of giving a license to go to heaven. A person will not survive a small resection or partial resection. Another beautiful, you see, this is quite a complex kind of tumor, but there is a method in madness of this tumor. These are all within dura. All within dura. This is the elevation of the roof of cavernous sinus. This is elevation of the diaphragm celli, elevation of the roof of cavernous sinus, elevation of the diaphragm in this pattern. And this is completely a defined kind of a problem. Giant pituitary tumors are giant in size, but they are not malignant in size and in behavior. They are not aggressive tumors. Grade 3 tumors I call when the roof of cavernous sinus is elevated by the tumor, I label them grade 3. Why I label them grade 3? Because the behavior is different. The pattern of regrowth is different. The pattern of recurrence is higher in these tumors. And some of these tumors will need radiation treatment, and I will discuss that issue with you. You see this diaphragm cell elevation, and this is the roof of cavernous sinus elevation. Now you see the beauty in this case. Just please concentrate on the beauty of this tumor. This is the chiasma that you are seeing. Can you see the chiasma? The chiasma is disturbed by this part of the tumor, not by the part of the tumor which is under the diaphragm. If you remove this tumor, maybe, I am not saying for sure, but maybe this compression does not go and the person may not improve in the vision. So you must remember, if you have to remove, if you have to get the vision back in this guy, you have to remove this tumor, and how to remove this tumor, you will have to decide. So diaphragm is here. The dural roof of the cavernous sinus is here. Dural roof of the cavernous sinus is here. This is under the dura of the roof of cavernous sinus. Some part of the tumor is under the diaphragm, but the majority of this tumor that you are seeing here is under the inside the cavernous sinus. So sometimes you say, I have done a radical resection, I have done a radical resection, but you have left this part of the tumor. You have left this part of the tumor because you have not entered into the cavernous sinus. There is a clear margin. There is a very clear margin between the sellar dura and entering into the cavernous sinus. And when you can remove this tumor, when you cannot remove this tumor are the issues that will depend on your very elaborate and heavy experience in dealing with cavernous sinus, in dealing with anatomy of cavernous sinus. My suggestion to you is, if you want to remove this tumor, the possibility of third nerve injury is extremely high because the neck of the tumor is small. When you enter into this cavity, the third nerve damage is a very big possibility, which you must remember. Grade 4 tumors are those which go beyond the diaphragm. They are not very common. In giant tumors, grade 4 tumors are those which transgress the diaphragm and encase the arteries of the circle of Willis. These tumors, I label them as aggressive tumors, or maybe I don't like to use the term malignant tumors, but they are quite aggressive, more aggressive because they are difficult to operate. They are dangerous to operate. You operate and you can create disaster in this situation. My question to you is, you have to understand when this tumor has become grade 4. And when it has become grade 4, your entire surgical strategy changes. And change you have to understand on the basis of these anatomical concepts. Encasement of the basilar artery, encasement of the internal, this is a part in the subarachnoid space, and this has to be understood. So this is the tumor, and this tumor. Sometimes when the tumor goes predominantly in the infratem, in the sellar, in the paranasal compartment into the clivus, even in these situations, believe me, my friend, even in these situations, there can be dura intact. May not be intact, but sometimes you can have dural intact. When the dura is not intact, they become aggressive. Here the bones are eroded. The bones may be eroded, but the dura is divine. Dura is God. Dural transgression is a rare event. Nature protects the dura. Tumor respects the dura, and that we have to understand. There is another situation that is very unique in our situation. One surgery done before. If one surgery has been done before, the tumor, you see the dural relationships may not be as defined. Now, this patient was operated by a transcranial route here, and then he was operated by a transnasal route. You see how the tumor has entered into this situation. Now here, there is no need for any confusion whether I will need microscope, I will need endoscope and all those things. You can put your finger and start removing this tumor. It is, it is not such a great, but of course you will not like to put your finger in the carotid artery and in the basilar artery. So you better use a nice microscope. I like to use microscope. I know many people like to do endoscope, but for me, I'm doing pituitary tumors for over 30 years or 35 years now. I'm very happy with what I'm doing with microscope. I don't think I need any other kind of instrumentation. So many a times, these tumors go into the paranasal sinuses. So I had written one article some years ago where I had written about giant pituitary tumors. You see the grade 4 tumors where it goes beyond the dura are relatively less. Grade 3, when the roof of the cavernous sinus is elevated, is quite frequent. Cavernous sinus involvement by giant tumor is quite common, and remaining confined within the, under the diaphragm without entering into the cavernous sinus are most common. And also we had written in our article, when the tumor is grade 1, it is histologically more benign. When the tumor enters into cavernous sinus, it becomes more aggressive behaviorally. When the roof of cavernous sinus is elevated, the tumor becomes more aggressive in behavior. And when, of course, it goes beyond the dura, it is like a very aggressive person. So there are various articles of mine as to how cavernous sinus and other things. Now, regarding the surgical strategy. So this is my favorite slide, which I have been showing for several years. Some of you or many of you have heard me talking on various forums. This is the baby, and this is the very strong uterus. No matter whether it is a twin baby or a single baby or a triplet, the uterus is the strongest muscle of the body. Do you know which muscle of the body is the strongest? Do you know this? I am sure you don't know. The muscle of the uterus is the strongest muscle of the body. It has the power to evacuate this baby. And doing cesarean section is like wasting your time. There are nature, have you ever seen an elephant getting a cesarean section or a horse getting a cesarean section? Because they depend on the beauty of nature. Unfortunately, we depend on artificial means, and we like to do cesarean section. On the similar lines, believe me, my friends, pituitary tumors do not need transcranial. This is like a cesarean section. You come and remove this anterior wall of the cell. Learn the art of breaking the tumor. Learn the art of breaking the tumor. Break the tumor, break the tumor, break the tumor, debug, debug, debug. Learn the art of breaking the tumor in a bleeding situation. Blood is there. If you start coagulating this tumor and you want a perfect hemostasis, believe me, you have never done pituitary tumor surgery. You don't know how to do pituitary surgery. This tumor cannot be removed for 5 hours or 10 hours. I do slow surgery. Or if you do slow surgery, you don't do surgery at all. This tumor has to be done quickly. This tumor has to be broken into pieces, demolished quickly and rapidly. These tumors do not need coagulation. If you say, I need a clean field, then you should not do this. You should not enter into neurosurgery. These tumors are not for clean field. Remove the tumor, debug, 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 and the whole diaphragm will come into your picture, and you will have this beautiful post-operative picture. Picture is all right. Post-operative, you go and see the person, he will say, doctor, I can see better. And after 1 month, he will say, doctor, I can see normally. These are not malignant. And you see him after 20 years, may not be any recurrence, and this patient will go on for normal life. On the other hand, you remove 20% of this tumor. You remove 30% of this tumor, it will lead to death. It will or it may, because these tumors are vascular tumors. They have propensity to bleed, and they bleed very furiously. Many of these tumors are cystic or necrotic or soft tumors. You see multiple cysts in this tumor. You remove this tumor, you come, and I can say I don't remember this tumor. I must have removed it 20 years ago, but I can tell you now without any doubt, this tumor I can remove in exactly 7 minutes. I will remove the anterior wall of the cella. If you say I will remove this plenum spinalis, you don't know pituitary tumor cell. If you say I will remove tuberculum celli, I want this picture, I need this, you don't know pituitary tumor surgery. I want to see from here, I want to put endoscope and see this part of the tumor. What endoscope you want to put here? You demolish this tumor, and within 5 minutes, this cyst will be evacuated, the entire diaphragm will come into picture, and that will be the end of the story. I removed this tumor in the whole operation in not more than 20 minutes. This is another tumor. You see, this tumor is predominantly blood. You see, this is black. This tumor, you come from here, remove the anterior wall of the cella, go laterally, quite lateral exposure, and start debulking and removing this tumor, removing this tumor, removing this tumor. The entire diaphragm will come into the picture, and more importantly, the person is cured. These are not malignant tumors. These are not behaviorally aggressive. You see, there is a nubbin here. Now this nubbin, of course, now you may say, I understand this. But 20 years ago, nobody in the world understood this issue. 20 years ago, all these cases done. 25 years ago, you ask anyone who has done pituitary tumor over 20 years, everybody was doing transcranial surgery at that time. Now you ask how many are doing, and I think you must give credit to our philosophy that this philosophy has completely revolutionized pituitary tumor surgery. And I have no doubt, if you have doubt, you keep those doubts with you. But there is no question. This nubbin is under the dura. This whole thing is under the dura. You remove this tumor, and you have now whether there is a residue here. Now what to do about this residue? Whether to give radiation or not radiation, I will discuss this issue with you. This tumor is grade 2 tumor, where it is entering into the cavernous sinus, and this cavernous sinus tumor has to be removed on some occasions. In non-functioning tumors, may not be any need. What will decide whether I can remove this tumor in this situation? Of course, when the tumor is functioning, you have to remove it. Of course, when it is acromegaly case, you have to remove it. Of course, when it is Cushing disease, you have to remove it. Otherwise, you will have to give radiation treatment. But in a non-functioning tumors, what will decide my aggression towards the cavernous sinus will be the nature of the tumor, softness of the tumor. And if it is soft, I just extend my exposure laterally, and I can enter into the cavernous sinus, and then I will remove this tumor on the basis of the consistency of the tumor. You just need to put your suction, and you can get the tumor from within the corners, and then you can safely get into the cavernous sinus. This tumor, I will say, this is simplest of all tumor any neurosurgeon will see in his lifetime. There is no tumor simpler than this. If you say this is a difficult tumor, then remain into that terrain of difficulty. This tumor, you come anterior wall of the cella, you see how big is this is a kind of a pregnant person. You remove this anterior wall, and you see you have a beautiful exposure, and within 10 minutes, this tumor is gone, and the patient is cured for life. This is another pregnant tumor. You see there's huge belly here, and there is necrosis in the tumor, and this tumor so there are whether to use endoscope and whether not to use endoscope.
Okay,
Whether not to use endoscope is an issue. And I have also already told you that I don't use endoscope. I like to use microscope. And my concept you will say, why I like to use microscope? I like to use microscope because I don't need endoscope. For pituitary tumor, I am not saying I will not use endoscope. I don't like endoscope. Oh, endoscope is, of course, you have to use endoscope for chordomas and for other paranasal sinus tumor, for CSF leak. In my own department, we have people who are doing endoscopic surgery, and they assist me on some occasions. I use for pituitary tumors. I have no question, no doubt. For this picture, you see, you are seeing, there is no need. If you ask any person, they will say, I will remove the plenum sphenoidal and this sphenoidal and that sphenoidal. No sphenoidal. You remove the anterior wall of the sella, enter into the confines of the tumor and remove this tumor. You see another beautiful tumor. Now here, this tumor was a philosophical beauty. Philosophical beauty. You see here, there is cavernous sinus involvement is not there. This tumor is not under the roof of the cavernous sinus. This is entire diaphragm cell. And I had removed this tumor 20 or 23 years ago, this tumor. And you see how the tumor can be removed from the nose. Just remove the anterior wall. No need to remove the plenum sphenoidal or tuberculum celli. This is another tumor which was removed. This is another tumor which is quite safely and quite simple tumor to remove. This is the tumor. You see there are some cystic changes. Sometimes there is blood within the tumor, and this tumor is removed. This is another tumor with this kind of extension, and this is immediate post-operative picture. This tumor, if you say I will remove transcranial today, nobody is going to excuse you. If you say, I want plenum sphenoidal removal and tuberculum celli, I think I will not excuse you for this necrotic tumor. You have to come from here. You see, when you use endoscope, you will have to use some 90-degree angle endoscopy or some 70-degree scope or something like that. Or if you, that is why you want to remove all this from here and come and deal with the CSF lying here. Why you have to deal with CSF? You have to deal with the dura, which is a beautiful structure. No need to, if you remove the, if you retain the dura, there is no need to even pack with fat this area. But whenever, if you will now ask me, when do you use fat in this area? Whenever I see CSF in my surgical field, I pack this sella and the sphenoid sinus with fat. That is my indication. And many of these
Okay. Just hang in there.
John,
Yes.
it's time to wind up, I guess. So once he starts back, then we will have to.
Okay, starting again. Hold on.
Again back, my dear friend. Up. Okay, now you see here, this is another tumor. You see, many of the people who use endoscope, they are very familiar with 0-degree endoscope. And they will probably say, I will need a different endoscope. I don't want to go into that controversy. Those who are using whatever instrument, basically your concepts have to be right. See this tumor, how it is going, and you don't have to come remove. You learn. John, you can hear me?
Yes, I can hear you. Yes, we can hear you.
Okay, so here the tumor, and this is the post-operative image. This is
Keeping my fingers crossed. Okay, be patient. Oh, I think we dropped off there, right? Okay, doctor, you're back on, but we don't have voice. We don't have your audio.
Okay, John.
Yes. What do you want to do, Ike?
Yeah, let's see. Let's see. Wait.
Okay. Yes.
Okay, again, I'm with you.
Okay.
Okay, so this is another tumor. I'm just showing you some examples of these tumors. Now you see here, this is one very fantastic tumor. You see, I had removed in 2001. And I had removed this tumor like this from here, and there was some residue. I could not remove this tumor. And I had put some fat here in 2001. And in 2007, this patient had come with a recurrence. So now my philosophy in very giant tumors, a very, very huge tumor, is many of these tumors with such residue in such huge tumors, I like to err in favor of radiation rather than having them come back with a recurrence. This is another tumor that you will see that I had operated in the year 2001, 20 years ago. And I had removed this tumor. This was a youngish boy, about 25-year-old boy. And this was my immediate post-operative image, and this guy ran away. He never came back to me till 2008. This is blood. This is not tumor. This is tumor, and you can imagine I had removed this tumor in this frontal area from here like this. So I was quite aggressive in 2001, 20 years ago also on my concepts. I had clearly, they were completely in my head at that time, and I had removed this. And so I am wondering as to when the tumor is more than 8 to 10 centimeter, whether I should give radiation even when the tumor is completely resected. You see this patient again came back in 2008 with a recurrence. This is another tumor. You see beautiful tumor with nubbins and going into the brain stem and going here and going there, and this has been removed. Of course, you will like to see some videos of these presentations, and I will show you in my subsequent presentations. You see this tumor going into almost touching the temporal bone, and this tumor, some residue, whether you want to give radiation or not, will come out to be an issue. This is tumor into the cavernous sinus, non-functioning tumor. I had removed a lot of tumor in the cavernous sinus, but some is remaining. Whether this some needs any kind of treatment will be a questionable issue. This is another tumor. You see how the roof of cavernous sinus is elevated, how the diaphragm is elevated, and this tumor has been resected. This tumor, both the cavernous sinus part is remaining. You see this chiasma is clear after the surgery. The vision has improved.
Okay. Okay, I have another delay here. Are you there, right?
Yeah, I am here, John.
Okay.
I'm seeing. I'll tell Professor Goyal that it's late now, so maybe I'll just call him and I'll tell him that we will wind up right now.
Okay.
Because we need to have questions right now. So people who are going to have questions, they can go ahead. Maybe anyway, Professor Goyal is going to do classes every day.
Okay, well, we could, whatever. Or maybe we could throw the questions out to the panel and have everyone talk about it. You want to do that, Ike?
Yeah, so let the panel start right now.
Yeah, just have a discussion of the questions. And why don't we start with Janky? Can you throw your question out? Jana Karam, ENT skull-based surgeon. Oh, okay, the doc's back. Okay, carry on, hopefully.
Sir?
Yeah, okay, I tell you.
So can you hear me?
Yeah, I told us back. I told us back.
No, I'm asking him.
Okay, just, you know what,
Yes, sir.
I will like to rapidly wrap it up, Ike and John.
Okay.
Yes, sir.
You see, this is another tumor which which is entering into the roof of cavernous sinus here. And this tumor was removed, but the roof of cavernous sinus tumor is remaining. Now, what to do about this? You know, I have mentioned that when the tumor under the roof of cavernous sinus is remaining, it is upfront radiation is better in my understanding today. It was not there earlier. Earlier, I never used to give radiation, but when in this situation, radiation is a helpful thing. Now you see here, this tumor is grade 3 tumor. The roof of cavernous sinus is elevated. The diaphragm is elevated. I have removed this tumor from here. The tumor under the cavernous sinus is remaining, and it has very badly recurred here. And you see, so now my philosophy is when it is tumor is here in the under the roof of cavernous sinus, it needs radiation. This is another tumor you see here in the cavernous sinus, and some is remaining, but the roof is elevated. Today I will like to give radiation treatment. This is another tumor. Here you see the roof of cavernous sinus is elevated, and I have entered into the cavernous sinus and entered into the roof of cavernous sinus. But you must remember, when you're entering into the roof of cavernous sinus, you can damage the third cranial nerve, and that is a very common big possibility. So this is a part in the roof of cavernous sinus, and there is some tumor remaining. I have mentioned to you that I will now like to give radiation treatment. This tumor you see going, the lateral wall is nubbined, roof is elevated, diaphragm is elevated. Whether to give, this patient underwent a transtemporal operation also, and this was the post-operative situation. This tumor is entirely in the cavernous sinus. You see here, there is nothing in the sella. This entire tumor is in the cavernous sinus, and this patient underwent a transcranial surgery for resection. This tumor, you see, both roof of cavernous sinus is elevated, roof of cavernous sinus is elevated, diaphragm is not elevated so much. This part of the tumor is removed, this and this part are not removed. This patient underwent radiation, and for a long period of time, this tumor is quite stable. Now, the issue about tumors which go beyond the diaphragm celli, the anterior cerebral artery is here, and the tumor is beyond. Now, what to do? These are like very solid cobras. You will not like to tickle this cobra. Either you come and kill this cobra, or you just run away from this cobra. So this is an issue. I am still trying to analyze these cases, and I cannot tell you for sure what I will recommend for these cases. But in this situation, you have to know that this is an aggressive tumor, and radiation is one option. Partial resection. You will say, I will remove 30% of the tumor. I'll remove 40% of the tumor. I am not sure that will be a good strategy of resection in these tumors. These tumors, you see, when they encase the anterior cerebral artery, encase the circle of Willis, these tumors become quite dangerous tumors. Now, another issue is when the tumor is aggressive, like the one I showed you earlier, grade 4 tumors, and tumors like this. Some of these tumors, like this tumor, you must do, you know, prolactin level can be high in these tumors. Tumors which do not respect the dural boundary, I have seen recently the treatment by drugs is quite an effective treatment. Cabergoline you give, and you, even when the prolactin level can be elevated in when it is not a prolactinoma. But when the prolactin level is high and significantly high, these tumors can be beautiful. This tumor has been treated by drugs, by cabergoline. So the dangerous issue, now you will ask me, what are the dangerous issues in giant pituitary tumors? One, it is very big. Now, what is very and what is huge will have to be really understood. I will say more than 6 centimeters. Higher grade tumor, grade 4 is bad. When the patient is drowsy, when the patient comes with altered consciousness, when the patient comes with hypothalamic disturbance, believe me, my dear friend,
Okay.
Yeah, John is dropped off again. Huh?
Yeah, well, I can see he's back on. Okay.
You just bear with me. If you have to see some beautiful cases, you have to bear with the smallest disturbance. You see, if it bleeds, you cannot say, I will run away. If you say, my cautery is not functioning, you should never run away because cautery is hardly required in it. If you say, this is not there and I will stop my operation, don't say I will run away. The issue is, dangerous issue in giant tumors is when the patient is drowsy. You can kill this person. When the patient is all severe, you can kill this person. When the patient has hypothalamic disturbance, believe me, you can kill this person. So you should be very careful when you are dealing with such situations. Now, what are my indications for radiation treatment? So these are some of my indications for radiation treatment. I will now rapidly like to show you some images before I wrap it up because I know the time is also an issue. I want to show you some tumors with fluid level. You see, there is a fluid level in the tumor. These are very easy tumors to operate, but these tumors recurrent very rapidly. You see, there is a fluid level. See, there are two cysts with fluid levels. Now you see this tumor, and if you see all the tumor cysts, there is a fluid level. These tumors are very simple to remove. You see, there is a fluid level in this. There is a fluid level. But the problem in this tumor is the recurrence rate is very high. You see this fluid level? You see this fluid level in this tumor? Fluid level 1, fluid level 2, fluid level, multiple fluid levels in this tumor. You see this fluid level in this tumor? Completely divided fluid level. Fluid level in the part which is in the cavernous sinus and the part which is going behind, there is a fluid level. There is fluid level here, fluid level here. There are multiple fluid levels within the confines of the tumor. If you see this giant tumor, if you see carefully, there are fluid levels in many of these cysts. Many of these cysts have fluid levels. I can tell you these tumors are relatively easy to operate. Fluid level. Multiple fluid levels in the tumor. Multiple fluid levels, as you can see. And believe me, my dear friends, believe me, when you see such a tumor, it's a very good day for you. And you can do a very beautiful resection in these tumors. But you must remember that these tumors will almost certainly recur. And you see this, my beauty queen, this tumor, divided into two components. And this tumor is a pituitary tumor, which is more aggressive than not. This tumor is, you see, there is a big tumor. Now, don't worry about this tumor. This is quite a, when you operate, you will find a tumor with blood and fluid level. This is a tumor with multiple fluid levels here. This tumor, which is going into the cavernous sinus, there is a fluid level, so it is much easier to remove. This tumor is easy to remove. Sorry, there is some repetition here. So you have to do a very beautiful reconstruction when you have to do. And thank you, my dear friends. I'm sorry for this very bad interruption, but bad interruption or no interruption. I hope I'm able to deliver my beautiful message to you about the tremendous, you see, pituitary tumors is our life. Pituitary tumor, we live with pituitary tumors. Pituitary tumors are common tumors. Pituitary tumors, you have to enjoy them. And you have to really work, understand tumors. It is not the question I want to use endoscope, I want to use. So John and I and other dear friends, if you have time, I have a lot of time. If you have time for me, I will be available for questions.
Oh, that would be great. You know, Doc, I'm not a neurosurgeon, but that's solid gold to me. That's why everyone stood. No one left the webcast. in spite of all the technical issues. So that tells it right there. Okay, questions from the audience. I guess you have to get off the screen share. Let me get you off there. Janky, I believe you had a question, right? Okay, questions from the audience, please.
John, are you screen sharing?
Let me stop sharing here. Okay. I guess I gotta stop share. Okay. Okay. I believe the screen's open now, isn't it? Can you guys see?
Yes.
Okay. Okay.
Any questions from participants?
Go ahead, Janky. Go ahead. Unmute and go ahead. Janky, unmute there. I know you're trying to. I guess let me see if I can unmute you on my end. Go ahead, Janky.
Hello?
Yeah, we can hear you.
Hello, Professor.
Oh, go ahead.
Professor Atul Goel?
It's a little jumpy there.
Hello?
Go ahead, Janky.
Professor Atul Goel, I hope you recognize me. Hello?
Yes, we can hear you.
Yeah, Professor Atul Goel, I hope you recognize me. I'm John from India. So it was a great presentation by you as usual, and fantastic. I have a few questions, Professor Atul Goel, sir. Hello, is Professor Atul Goel there?
Yes.
I can't see him.
Yes, we're here. We can hear you. Well, as you can see, we're learning the tech today.
Hello?
Yeah, go ahead.
Professor Atul Goel, I just have a question to you. In case a patient comes with elevation of the roof of the cavernous sinus, what we call as the medial compartment, with a third nerve palsy already by the tumor, then would you again go inside and chase the tumor, or would you still prefer irradiation? Hello. First of all, I want to thank Professor Atul Goel, sir, because I'm a student, and I really thank him because he's contributed to our textbook also. He's to me, the father of pituitary surgery. But I have some questions from his presentation. So if he can be kind enough to answer the question, it'd be great.
Thank you. Did you hear that, Atul? No, I don't. You're muted there, Atul. We'll learn the etiquette slowly. You're muted there, Atul. You're still muted. Okay, go. Oh, you were unmuted there. Go ahead. Go ahead.
Okay. Can you hear me now?
Yes. Yes.
Now the question that you have asked me is about the third nerve. You must remember, whenever there is third nerve affection in the pituitary tumor, more often than not, it is due to pituitary apoplexy. It is the tumor by its size will never take the third nerve unless there is a small or big bleeding in the pituitary gland, and then it will take the third nerve. And when it has taken the third nerve, if it has not resolved in time, you have to remove the tumor, and you may not go into cavernous sinus. You remove the cellular component, you remove the largest clot, and the third nerve will improve. Third nerve improvement is a rule rather than a luxury. This is my answer. Third nerve affection is almost certainly a consequence of a bleed within the tumor. It is never the size that affects the third nerve.
Okay. Another question?
Yeah, thank you, sir.
Come on, now's your chance. I'm sure there are, but people just don't know how to operate this tech, don't feel comfortable with it yet.
I have one more question, Professor.
Go ahead.
Yeah.
Yeah, you said that if you have fluid levels, apoplexy, then the chance of the recurrence chance is higher. The recurrence rate is higher. What is the what is the mechanism behind it? Are there any published studies, or have you published this in literature?
Yes. My paper is published. I showed that paper actually
Why
here.
does it recur?
You see the tumors which bleed.
Why does it recur?
Yeah, I'm answering that question. The tumors which bleed are inherently more aggressive. The tumors which bleed are inherently aggressive. You see the tumors which do not bleed. There is a difference between tumor which bleeds and tumor which does not bleed. So tumor which bleeds is more aggressive than the tumor which does not bleed. And tumor with multiple fluid levels, which I have reported a very big series of more than 100 cases. About 15 years ago, I had reported that series. And I had analyzed the tumors, which tumor will recur, which tumor will not recur. And for your information, another information I'll give you. There are some tumors like trigeminal schwannomas. If they have fluid levels in trigeminal schwannomas, they recur. And if you have done 100 trigeminal schwannomas and there are 10 tumors with fluid level, and if there are 2 recurrences, at least one of them will be with the fluid level. And there are several other schwannomas in the brain with fluid levels, the recurrence rate is higher. And this is what I have seen. Now I have got, my experience in pituitary tumor goes beyond 4,500 cases or even more. And now I can say with great confidence, and I can tell you, when there is a fluid level, the tumor surgery becomes much more easier. But the recurrence rate in these tumors, I'm not saying they become malignant. I'm not saying they become beyond your borders, but the recurrence rate is higher than non-fluid tumors.
You said that on grade 3 tumors, you prefer giving radiotherapy. The question is, if it is going to be a liquid tumor or if it's going to be a solid tumor. Let us presume that you have a liquid versus a solid tumor. Would you still, even if it's going to be a liquid or a solid, do you go in for radiotherapy? Is the protocol same, or does it differ for the consistency of the tumor?
You must know one thing. I don't like radiation. You must keep in mind very clearly and very solidly, you must know this. I have never recommended radiation treatment unless it is forced on me. I don't like issues like gamma knife, and I like knife. I'm a surgeon. I want to operate. I have never, for acoustic tumors, some people will say, I like gamma knife. Oh, go on, nonsense. What gamma knife? You operate these tumors. These are surgical tumors. These are not for radiation. There are very few indications for radiation. So in general, I am not for radiation. In general, even if it is grade 3 or grade 4, my strategy is a very radical surgical strategy. I like to operate. But grade 3 tumors, when I have left behind in the cavernous sinus and in the roof of cavernous sinus, I have seen over the period of time that many of these tumors recur if I have left behind. If I have not been able to remove these tumors. In that situation, I've shown you some tumors which have recurred. And with my experience now, which is over 35 years, I will say that if you have left behind tumor in the cavernous sinus roof, I will now err in favor of radiation because the recurrence rates are very high. And if I am not reoperating, if I am reoperating, suppose there is a cyst, and suppose the patient has some symptoms, of course, then I will reoperate. But when I am not reoperating, and when there is a recurrence under the roof of the cavernous sinus, I err in favor of radiation.
So after radiation, Professor, have you followed up these patients? Do the tumors regress completely? Do they grow, or what is the change which occurs after radiation? And have you had a chance to operate on cases who have been radiated already by other centers? And if so, is there any variation in surgical strategies?
No, pituitary tumors are quite radiosensitive. Pituitary tumors are not, you see, pituitary tumors are radiosensitive, and the radiation works very effectively. And I will, I work with a very big radiation. I work with Tata Hospital, and I work with radiation oncologists who are the leaders in the field of radiation oncology. And I will get the exact figures. I don't want to give arbitrary figures to you. Many of my patients, and we have written with them with the radiation oncology. You know, Dr. Jalali, I work, who is the leader of radiation oncology in our country. I work with Dr. Tejpal Gupta, who is a real king of radiation oncology in our country. They will be able to give you exact figures. But pituitary tumors, if you are not able to remove, surgery number one preference. If you are not, even for Cushing disease, surgery, you say, I give radiation, I will say, what you are doing? You should not give radiation, you should remove them. But suppose you have removed them and the Cushing disease is lasting, then radiation treatment is an option. And with my partners in Tata Hospital, we have developed a very fantastic experience of radiotherapy in pituitary tumors and in patients with Cushing disease, in patients with giant tumors where there is a residue. And I can give you some exact figures, and we have published quite elaborately with them, and you must read the literature on this.
Okay, Dr. Weil has, thank you. Dr. Weil has a question. Your strategy was solid pituitary tumor in resection from transnasal approach. Did you understand that?
What is the question?
Okay, Dr. Weil, I believe he's from Sudan, asks your strategy with solid pituitary tumor in resection from transnasal approach.
All my tumors are operated by transnasal approach or sublabial approach, which I have not yet left. I like sublabial transsphenoidal surgery, which I have not left. I like my approach, and transcranial approach is quite rarely used. I'm not, you will ask me which are those indications for transcranial approach. Very rarely. But when there is a recurrence of tumor, which is mainly in the cranial compartment, I sometimes like to do a transcranial approach. But primarily, I don't think some giant tumors, grade 4, maybe I will recommend transcranial. Otherwise, all my tumors, pituitary tumors, on the basis of radiological pattern understanding, I do transnasal or sublabial approach.
Okay. More questions? Let me just scroll through here. I'm sure there's some here. Go ahead. Okay.
Hello, Professor.
Go ahead.
Professor,
go ahead.
Can I have a question again? My
Go
question
ahead.
to you: Why don't you like the endoscope?
That is a very difficult and dangerous question in front of Janki, who is smiling with his mustaches.
He wants you to go out on the limb.
You have really put smile on many faces. But you know what? I'm now, more than 35 years experience with microscope, with so many tumors. I said that I do like endoscope for some tumors, like extradural tumors in the paranasal sinuses, like some chordomas, some other malignant tumors for CSF leakage, for some indications. But for pituitary tumors, you ask me, pituitary tumor, no way I will change, because I'm so beautifully poised with my approach, with my handling, with my view, with my philosophy, and with my understanding of that anatomy. I can go to any extent in the cavernous sinus with my transcranial approach. with my manipulation of my instrumentation. And I of course do not say that endoscope is bad or this is bad or that is bad, but for me, I continue to do with what I do, and I like and I'm happy with what I'm doing. But I will recommend you, if you are good in endoscope, like some people on the screen are, and some of them are very good in it. You know who are, and you have seen them on the screen many times. You should continue doing, and I'm recommending, and I'm not saying you please don't misunderstand what I'm saying. And even if you are,
I understand.
whether you are young or whether you are old, that is for you to decide. But for me, no way I will change.
Okay.
Hello,
Next,
Professor.
go ahead. Next question.
Yeah, I want to ask something.
Go ahead,
Hello,
Sunil.
Yeah, Professor, I am Sunil Roniar, currently in China and doing my residency here. Like
Yeah.
you mentioned, like cystic tumors in the pituitary gland, like these are very prone for the recurrence. Like I was just thinking, like what tumor markers are responsible for those recurrence?
Did you get that, Dr. DeGuel?
Yeah, I got that question.
Okay.
And I'm sorry, I will not be able to answer that question. My issue is, you know what, in general, I don't tax my brain too much. I like to operate, and then my wife is also a neuropathologist. Some of you may know her. And I just send it to the neuropathology department, and she does all kinds of markers in the world. And sometimes she gives me lectures on this marker and that marker, and this marker is a good marker and that marker is a bad marker. I don't really understand. I depend on my wife. She's a very fantastic neuropathologist, and that's the answer to your question.
Thank you, Professor.
We should have her do a webcast, Dr. Goel.
Yeah, she will do.
Okay, we could do it. We can set it up. Okay, next question. Go ahead, step up. I'm sure, let me go through the, someone raise a hand. Go ahead, Mohammed. Abdel Khalik, Mohammed, but you raise your hand. Just go ahead and unmute yourself. Go ahead.
Yes, sir. I'm asking.
Go ahead.
Yes, I'm asking about the radiotherapy. When did you prepare before when you get the tumor or after?
Did you get that? You got that, Dr.
Yeah.
Goel? Okay.
Yeah, radiation. You see, unfortunately, I had to rush with my slides, but I have got very specific, and also I have published this. You must read some of my publications on this subject. And I like to give radiation on very specific times. My indication for radiation is when the tumor, I have left some tumor behind in a case which is even grade 1, but which is more than 6 centimeters. I like to give radiation. When I have left some tumor behind in grade 3 under the roof of cavernous sinus, I like to give radiation treatment. For grade 4, I must tell you, even now, I am still trying to analyze my philosophy. And I don't want to give you a very specific answer. But today, I will say radiation has a big role in grade 4 tumors. And the role of surgery in pituitary tumors in grade 4 tumor is a questionable role even in my mind. And maybe I can answer you after 5 years or 10 years. This question will remain in my mind.
Very good. Okay, next question. Next question, please. I'm sure there are more. It's just a matter of people getting used to this technology.
Hello.
Yes, go ahead. Go ahead.
Dr. Goel, sir, do you have any specific
is some issue.
Yeah, for the bandwidth.
Repeat the question, Janki. No, wait. Wait.
Have you ever staged, like doing a staged removal? Indications
Staged removal,
for staging the surgery into the surgery. Do you stage? There are some indications for staging.
I will like to answer that question. Can you hear me?
Yes,
if you are able to hear me, lift up your hand. If you are able to hear me, lift up your hand. Okay. Stage surgery in pituitary tumors is a highly dangerous concept. I will never like to stage the surgery in pituitary tumors. I have staged the surgery in some meningiomas. Even in meningiomas, I don't like to stage the surgery. But in pituitary tumors, staging the surgery is a very dangerous. Never do it. Never do it. Unless you are forced. Unless you cannot just remove it, then you have to. And I can tell you that there are some situations where you cannot remove. I'm not saying that I can remove all the tumors. You don't go by wrong ideas. See, the issue is I'm seeing so many giant tumors. I have traveled around the world. I've never seen such giant tumors. Any presentation of this kind in the world I've never seen. So I don't know whether these giant tumors come to me or not. So I can tell you, even if I'm doing a number of tumors, that does not mean that I can remove all the tumors and all the tumors in 100% cases. But I want to remove all. And I have, with my experience now, I remove majority of tumors. But I don't want to stage the tumors ever. That may be a very wrong thing. Did you get my point, Janki?
Perfect. Actually, the big tumors, they search and come to you, Professor, because of you, because of Professor Atul Goel.
Okay, excellent. Okay, excellent. We have to wrap it up, Dr. Goel. Are you speaking tomorrow?
Okay.
Tomorrow, Dr. Goel?
Yes.
Oh, excellent.
I am going to talk to you, John, for next 1 month, daily.
Okay, well, you know what, Dr. Goel? We had 100 people, and I have a limit of 100 people. I have to upgrade my account now because of you. Okay, and please, we'll improve your internet connection. And thanks everybody for coming. Thank you. See you tomorrow.
Thank you, John. Thank you, John.
Bye-bye.
Thank you, Professor Goel.
Thank you, Ike.
Yeah, we will see you tomorrow then.
Okay, Ike. Thank you.
Okay,
Thank you
Ike.
very much.
We'll see you tomorrow.
For 1 month, you have to see me.
Okay, excellent.
Bye-bye.